Thanks, everybody, and thanks for the invitation to join you today. I'm really excited to be here. I've been obviously reading for many, many years about the Houston area and specifically about this hospital and your steeped history in mechanical support. So it's a real privilege to be here to talk to you about acute circulatory support. So I'm going to be talking about a number of things, and as you'll notice from my disclosures, I work with a lot of different companies in this field of acute support. So I'm conflicted, but I'm also pretty heavily conflicted, and equally conflicted. So what I'd like to do is make sure that the best grand rounds are those that are conversations. So if you guys have questions, if things don't make sense to you, please certainly save your questions, and let's make sure that you guys get a better understanding of all these devices. So I'm going to talk first about acute mechanical circulatory support. 20 years ago, when I was in training, this would have meant that you were a balloon pump specialist. In the year 2016, acute MCS has changed radically. So we're going to talk about this rising tide of pumps that are coming out in the acute circulatory support arena. And then we're going to talk about this concept of the hemodynamic support equation. So the foundation for all of this work is a fundamental understanding of invasive hemodynamics. So I'm going to walk you through our understanding of these devices. And then we'll talk about the latest advances in acute circulatory support with particular reference to the right ventricle. And then we'll also, at the end, if we have time, we'll get into this concept of changing the paradigm for AMI management from primary reperfusion to primary unloading, and that's the door-to-unload concept. So the field of percutaneous circulatory support is growing exponentially. What you see here is a graphic representation that I put together of all the devices that exist for left ventricular support as well as right ventricular support. And very similar to our durable VAD colleagues, these can be categorized as pulsatile systems or continuous flow systems. The continuous flow systems can be broken down into axial flow as well as centrifugal flow. And of the axial flow pumps, we're talking about the INTERMACS device and then the percutaneous heart pump. Very happy to have Methodist join us on the SHIELD II study for the Thoratec PHP device. And then on the centrifugal flow side, we're talking about VA-ECMO as well as the TandemHeart extracorporeal centrifugal flow pumps. For the right ventricle, this is also an expanding area. So right now, historically for right ventricular failure, you'd be looking at VA-ECMO. Perhaps you do RAPA bypass with a TandemHeart device. Now we've got two new devices that have come out on the scene, the INTERMACS RP, so a single stick axial flow pump, RAPA bypass, and then the ProTech Oxy RVAD. So this is a dual lumen built off the Avalon cannula construct, basically designed for RAPA bypass through the IJ. And this one, the experience is growing. This is probably the most recent addition to the family of acute support devices for RV failure. So as you can see, innovation in this field is growing rapidly. What we're seeing now is this question of how to use these pumps, how to use them appropriately, where to use them, where are the algorithms in terms of using these types of devices. So from a interventional heart failure perspective, the gold standard in mechanical LV unloading is a durable VAD. And from this perspective of an interventionalist, this is what a VAD often looks like, is basically a fluoroscopic image of a HeartMate 2 device with a pigtail and doing a V-gram on these pumps. And from the pressure volume loop perspective, this is a critical aspect of understanding these pumps. From a normal pressure volume loop, once you activate an LVAD, which is LVAO bypass, what you see is a significant reduction in pressure and volume within the left ventricle. And it's important to note also that under normal conditions, the pressure volume loop in the LV looks like a square. There's isovolumic contraction and relaxation, which are energy-dependent mechanisms, meaning that the LV has to work in order to contract and it has to work in order to relax. But once you put an LVAD in, you start to get a triangular configuration to the pressure volume loop. And to us, that's one of the hallmarks of unloading, because now you've taken away those energy-dependent mechanisms in the left ventricle, and now the pump has taken over the majority of stroke work of the ventricle. And so this triangular shape with a reduction in pressure and volume is what we would define as the gold standard for LV unloading, if that's your primary objective. Now, this is the recent appendix from the allocation guidelines for organ transplant that was recently debated online. It's quite an interesting blog if you ever get a chance to read it. But what I focused on is Appendix A, because in Appendix A, our advanced heart failure colleagues around the planet basically listed all of the devices that qualify for classification of UNOS allocation. And in here, they mixed together all of the percutaneous acute circulatory support pumps with durable pumps. And what this started me thinking about was the fact that I think there's a question in the field about acute support devices and what their purpose is. And so one of the things that I'd like to leave you with is this statement that acute mechanical support devices are not VADs. We commonly call them percutaneous VADs, but if you think about it, a durable VAD, the primary objective is outpatient discharge. These are stable patients, but they're sick. The surgical approach is a cardiotomy, and the goal for success is bridge to transplant or destination. And withdrawal of care from a surgical VAD would be considered failure. But in the acute world, it's a little bit different. These are inpatients. Our goal is inpatient stabilization. These are sick and unstable patients. It's a percutaneous deployment by a medical team, an interventionalist team, or a heart failure team here at Methodist. And the outcome metric of success is recovery. So what we want to do is put in these devices and have people recover, stabilize, and hopefully explant so they go home with their own heart. Or the alternatives are durable MCS or bridge to transplant. And withdrawal of care and acute support is success in select cases. You put in a device, you find out they're not a candidate for advanced therapies, and you take the device out and you put them on palliative care, or you let them expire appropriately without bridging them to a durable VAD or to transplant. And that's a very difficult thing to swallow, is that success is withdrawal of care. And so our palliative care folks find that very interesting. But these are some important differences between acute MCS devices. They are not VADs, and we should start thinking about them a little bit differently. So when I think about an acute hemodynamic support device, I hear all sorts of terms. I hear, I'm going to put them on circulatory support. I'm going to put them on an unloading device. I need to get coronary perfusion up. So when I think about the purpose of these devices, there's a very simple equation. This is the acute hemodynamic support equation. The optimal acute support device should provide circulatory support, which means that you've got adequate systemic perfusion measured by an increase in your mean arterial pressure. It should provide ventricular support, meaning that you are unloading the left ventricle or the right ventricle, whichever ventricle you're targeting, which means a reduction in pressure and volume within the ventricle. And then it should provide coronary perfusion. So by virtue of increasing your mean arterial pressure, dropping your LVAD, your transmyocardial perfusion gradient should improve. And so if you can achieve all three of those, then you've got an optimal device that solves the hemodynamic support equation. And the problem is that a lot of the devices that we currently have will take care of one or two aspects of the equation, but not all of them will solve all three components of the equation. So the first device that you're all very familiar with is the intra-aortic balloon pump. And as Jerry and I were talking about, the issue is that a lot of people forget how to use a balloon pump. And I think that's a major issue. So we in the cath lab, we are faulted because we put in the balloon pump, nobody looks at the tracing, we send it back, and the person who looks at the tracing is actually a nurse at the bedside who's recording it on strips or recording the diastolic augmentation, et cetera. And the students are trying to figure it out, and most physicians aren't sitting there trying to explain to them how to do timing and optimization. But if you put in a balloon pump, this is what you should be seeing in terms of an optimal effect of a balloon pump. You activate the balloon pump and you see diastolic augmentation. Everybody's eye goes towards that. But actually what you need to be seeing in the advanced heart failure patient is some degree of ventricular unloading. And that means that the systolic pressure points have to come down. If you don't have systolic unloading with an intra-aortic balloon pump, then this afterload reducing device is not adequately unloading your left ventricle. It's providing diastolic augmentation without the unloading effect. And so that's just a simple mechanics of an intra-aortic balloon pump. So I also talked with your group here yesterday about going one step more basic in our exploration. That's how I was taught at Hopkins to think. And what we've started doing is introducing conductance catheters into clinical practice. So these are pressure volume loop catheters. You guys have the same system here, the Inca system. And I call this a pigtail with a purpose. It's basically loaded over an 025 wire. It's retrograde put into the LV. And then we can basically now generate pressure volume loops. So one of the studies that we started embarking on was whether or not balloon pumps have an impact in patients with advanced heart failure. Patients with an EF of 10%, pre-VAD, who are going in and getting a balloon pump. And the question often is what is the balloon pump doing in that setting? So here's some of our preliminary data that we're now putting together in manuscript form. And what you're seeing here are pressure volume loops taken from live patients in our cath lab. We took 10 patients who had basically normal heart function, non-obstructive CAD, and this is the normal pressure volume loop. Isovolumic contraction, relaxation, nice peak pressures, nice large stroke volume of about 70 cc's. We then put the balloon pump, took the patient who was pre-LVAD and put a conductance catheter in, and this black bar here, this little loop here, represents the patient with advanced heart failure. And all of a sudden, the stroke volume is now about 10 to 15 cc's. And as you can see, they're dilated, the LV volumes are elevated, the LV pressure generation is significantly reduced. We activate a balloon pump, and this is the acute effect within a period of about 15 minutes, is we get a drop in systolic pressure, We're not seeing much of a change in volume, and what we're seeing is there's not much change in stroke volume in these advanced heart failure patients. So when we look at this quantitatively, what you're seeing here in these graphic bars, these are pairwise analysis of what we called responders or non-responders. And a responder was defined as somebody who had a cardiac index that was augmented by 20% or greater. And if you didn't augment your cardiac index by 20% or greater, then you were considered a non-responder. And what we found was that in the patients who were responders, there was a significant drop in end systolic pressure. There was no change in end diastolic volume across the board. But this drop in stroke work of the left ventricle was driven by this drop in pressure, not in volume. So remember, the primary unloading device has to drop pressure and volume. And what we're seeing here is a drop in pressure, but not a drop in volume. So I wouldn't consider a balloon pump as an unloading device. I think it would be, at best, probably a temporizing mechanism to stabilize someone in heart failure. And these are the pressure volume loops across the board. I show this mostly for Arvin to basically recognize that this is a painful process. These are some crazy loops you're looking at here. The advanced heart failure pressure volume loop is a very complex substrate. These are all the normal pressure volume loops, nice isovolumic contraction relaxation phases. But in these groups, you've got a lot of wobble going on. And basically, these loops are all over the place. But this is full disclosure of what it's like to try to do this type of analysis. But for the most part, again, as we look at that, you think about the LVAD loop I showed you. This is the IABP loop where you get a drop in pressure but not much change in volume. And so that's the challenge of balloon pump, is that it'll temporize things, it'll increase your diastolic pressure in those responder groups, but it won't effectively unload. The other thing that we realized from this study is that if you have RV dysfunction, meaning that your right atrial pressure is elevated, your PAPI is low, or your RA wedge pressure ratio is elevated, then you're more likely to fall into that non-responder category. So it suggests that the balloon pumps do require some degree of intact RV function. And our take-home message from this analysis is that counterpulsation requires pulsation. If you don't have antegrade pulsation from the native ventricle, balloon pump's not going to have much to counterpulse against. And so that's where we've been studying this. And other groups have been doing the same thing. Susie Joseph and Doug Mann put out their analysis of balloon pumps in advanced heart failure. And what their paper basically took away was that if you had a lower RV cardiac power output, that you also had a more likelihood of becoming a non-responder if your RV is not intact. So the next device that we studied was the TandemHeart device. And we started off as a major TandemHeart center. This is a left atrial ephemeral artery percutaneous bypass system with an external centrifugal flow pump. And essentially, the primary effect of the TandemHeart device, it worked very well for us for many years, but the challenge of the transeptal became more of an issue for our interventional groups on call. This is the normal pressure volume loop before we activate a tandem device. Here we activate the tandem device, and the green dots are volume and the blue dots are pressure. And what you see here is once we activate the tandem device in that LAFA configuration, all of a sudden you see a significant drop in volume, but you don't see much of a drop in pressure. Okay, so remember, our goal is to drop pressure and volume. And in this case, what we've done is we've gotten rid of volume, but we haven't gotten rid of pressure. And so we've, again, taken now the other half of the equation. And with this LAFA bypass system, we're reducing LV preload very effectively. But at the same time, we're pressurizing the arterial system. And so as a result, the LV still has to generate pressure. And so that's the counterintuitive part about the tandem system, is that it'll very effectively reduce volume, but you're still increasing load on the device, on the left ventricle, and as a result, the pressure points don't come down. So the next device that we started to study is the INTERMACS system. And so, as I said, we started off as a TandemHeart balloon pump center. There was a lot of questions about INTERMACS, especially as it related to the 2.5 device. We stopped using the 2.5 because we weren't finding much of an effect. They brought us the 5.0 device, and I said, well, let's see what the 5.0 does. And before we even put it in a patient, we started studying it in our preclinical arena. And what we were studying is basically, what is this device going to give us that reduction in pressure and volume? So here's the pressure and volume loop at baseline. This is with the device sitting across the aortic valve, so you get this skewed upstroke here. This is volume, this is pressure. We activate the 5.0 device, and very consistently what we were seeing was essentially a melting away of that pressure volume loop. And essentially what we wanted to see is what we were visualizing, which is this drop in pressure and this drop in volume simultaneously. And most importantly to me was this final configuration of the triangle. Because the triangular configuration, as we said in the LVAD loop, is one that takes away isovolumic contraction relaxation. You've now got basically a flaccid bag that's not working. All those energy-dependent mechanisms are gone, and the 5.0 is essentially taken over the LV, very similar to what an LVAD would do. And I think that's been your experience here with your 5.0s. It's been our experience up at Tufts as well. So we've studied this, we quantified this. This is in the slide deck, but we published basically comparisons of the CP device, which was also a question for us, is this enough? And with the CP, we found a very similar configuration, drop in volume, drop in pressure, compared to the Tandem device at matched flow rates of 3.1 liters per minute, where we got volume reduction, but we didn't get pressure reduction. And then, of course, with the Tandem, you can amp up to a higher magnitude of flow to 4.4. And again, we weren't seeing those pressure points come down, which is what we were looking for, especially to make sure that the LV is not working. And if you notice, again, the configuration, even at 4.4 liters, is still a square. There's still isovolemic contraction relaxation with an LA preload device. The other advantage for us with our 5.0 devices is that we can now ambulate our patients. So now our patients with 5.0s actually are now engaged in rehab. These are patients who are surgeons when they walk by and they say, oh, this is someone you want to look at for VAD. And if they're gray and they're ashen and they're not peeing, the surgeon just keeps walking. But if they're sitting up and they're riding a bicycle and they're pink and they're peeing, then the surgeon will stop by and actually take a closer look at this, what was considered an INTERMACS 1 or 2 patient who's now stabilized. So one of the issues that comes up with the INTERMACS devices, these microaxial flow catheters, is hemolysis. And we talked about this a little bit at dinner last night, but we started to really get concerned about this signal of hemolysis when we put in the first original version of the CP device. And so we've created a protocol where we actually measure a baseline LDH and plasma-free hemoglobin before implant on every microaxial flow pump, and then Q12 hours for 72 hours. And what we found was that in the majority of these patients, we're putting it in for cardiogenic shock, that a lot of these patients with cardiogenic shock were coming in with massively elevated LDH levels. And in fact, they were already far above the 2.5 of the upper limit of normal, which is our INTERMACS definition for hemolysis, and they were in the range of the thousands point for shock. And then when we activated a 5.0 or a CP device, the LDH has basically stayed flat. And we weren't finding that there was a significant change with LDH as a marker of hemolysis. And so this is the 5.0 experience, this is the CP experience with LDH, and the baseline values were elevated. So then we looked at plasma-free hemoglobin. And the baseline plasma-free hemoglobin was actually a much better marker. We found that at baseline, very few patients had a plasma-free hemoglobin, certainly above 40, and a couple had them above 20. But when we activated the pumps, what we found with the 5.0 is that there was virtually really no significant increase in plasma-free hemoglobin. With the INTERMACS CP, we did see a variability in terms of the first 24 hours. Some patients had a significant hemolytic response, and other patients didn't have any hemolytic response. And then we tracked those numbers over time, and they all basically started to come back down below the threshold. So this is putting the device in. You don't realize that it's not in the right position or there's some issue with it. You either explant it if you're in this range, or you start to readjust it and the plasma-free start to come down again. So when we started to look at how we can define hemolysis in acute circulatory support pumps, we had to modify the INTERMACS definition. And what we did was we essentially said that if you had a plasma-free hemoglobin greater than 40 within the first 72 hours, not after implant, and we excluded patients who had a plasma-free hemoglobin above 40 before implant, and if they had clinical symptoms of hemolysis. And with this analysis, what we found was that if you had a delta plasma-free hemoglobin, meaning that your plasma-free hemoglobin jumps by 25 points within the first 24 hours after implant of an INTERMACS device, then you were more likely to have clinical markers of hemolysis. And so that was our new way of measuring whether or not people are developing hemolysis on these pumps. What we found was that the LDH, the delta LDH, actually didn't help at all. And the issue there is that when we looked at the ROC curves, we found that the predictive value of this delta plasma-free hemoglobin was far more powerful than a change in LDH, especially in the shock population. And this becomes very important because we started getting phone calls from people all over the U.S. saying, hey, I've got someone on an INTERMACS device, they're hemolyzing. I said, well, how do you know they're hemolyzing? Well, the LDH is 5,000. I said, well, what's the condition? Well, it's an AMI shock patient. I said, well, I'm not sure the LDH is coming from the hemolysis from the pump, so you got to make a decision. And a couple times the pumps were removed because of high LDHs and patients expired. And so the real importance of trying to study this hemolysis question is we don't want to withdraw therapy from somebody because of a mistaken diagnosis of hemolysis based on an LDH, which is what we're taught in the VAD, durable VAD literature. But in the acute MCS literature, it's probably the exact opposite. You want to follow the plasma-free. You don't want to follow the LDH. So the issue that this hemolysis question is obviously one of the big ones, and it's related to the size of the device, the tip speed, the exposure time along the impeller blade lengths. And now there's a next generation axial flow catheter that you have here on the shelf. I'm waiting, I'm hoping, I'm excited to see you guys implant the PHP. This is the HeartMate PHP device from St. Jude Thoratech. It's a 14 French sheath. It's a 24 French impeller. As you deploy this across the aortic valve, you unsheath basically this impeller blade up to 24 French, and you can get flows on a bench up to about 8 liters per minute. So you're essentially now putting in through a much smaller arterial incision, basically the equivalent of a 5.0 plus type device. SHIELD 1 is a high-risk PCI trial that was presented at TCT. SHIELD 2 is the multi-center study we're doing in the U.S., which randomizes patients to PHP versus Impella 2.5 for high-risk PCI. But of course, the major potential advantage of the PHP device is related to its use in cardiogenic shock, where you can really get these patients unloaded effectively. So the other device that we use commonly at Tufts is VA-ECMO, and this is percutaneous peripheral VA-ECMO. So I always underline peripheral because we're not talking about open chest thoracotomy, central cannulation ECMO. This is cath lab, cardiogenic shock, VA-ECMO, bedside ECMO. And this is the baseline pressure volume loop before activating VA-ECMO. And what we're seeing here is after we activate VA-ECMO, that the pressure points in the LV start to climb, and the volume points haven't changed much at all. So the effect of taking blood from the venous system, putting it through a centrifugal flow pump, oxygenating it, and then pressurizing the arterial system without a direct vent mechanism in the left ventricle is that you're going to very effectively provide circulatory support. Mean arterial pressure is going to go up, but so is your LVADP and so is your LV pressure, and that's the amount of work that the ventricle has to do. And remember, for the unloading configuration, we want to see a reduction in pressure and volume and a loss of isovolumic contraction relaxation. And with VA-ECMO, we don't see that. We see increased pressure. We still see preserved contraction, isovolumic contraction relaxation, and we're not seeing much change in volume. So our view is that VA-ECMO is very effective for circulatory support. It will take your patient who is coding, and it will give them a blood pressure. It will provide multi-organ perfusion, but you have to add on top of that some sort of vent mechanism to prevent LV distension in order to get that unloading effect. And I know you guys are familiar with that. We just published this paper looking at the comparison of VA-ECMO versus Tandem. And the only difference between the two, they're both extracorporeal centrifugal flow pumps, is the location of the inflow cannula, RA versus LA. And that simple movement of RA versus LA basically changes the effect on the pressure volume loop considerably. And so this, of course, has led us to study this more intently. The one thing you don't want to see, you'll never see this tracing, I hope. This was a 30-year-old kid who came in with biV failure and shock into the cath lab. Arterial pressure here, PA pressure here. We put him on VA-ECMO, and immediately the arterial pressure's up. That's the circulatory support mechanism. And you can see that there's still pressure generation. He's pulsing through VA-ECMO with this. You can imagine what that pressure volume loop looks like. Within about 10 minutes, as we're suturing all the cannulas in, PA pressure, all of a sudden I'm told, is 80. And I say, wait a minute. So I look over, and the PA diastolic I'm reading is at 100. And so I look over, and I say, well, is the transducer on the floor? Transducer's not on the floor. And at this point, our patient started to have pink frothing and hemoptysis through the ET tube. I put in a double lumen Langston catheter, which I recommend people use to understand VA coupling with these pumps. And the Langston measures LV pressure and AO pressure simultaneously. It tells me what's the status of the ventricle. And when I put in the Langston, the LV tracing is here in purple, and our LV EDP is about 95, and our AO pressures are matched. We then did a pullback. This is the shortest LV-AO pullback you'll ever see. And essentially, the LVEDP went from 95 to 95. And so we put in the Impella device to unload, and immediately the PA pressure came down to about the 20s. So this is that concept of venting, which is really important when you guys do ECMO, and I know you guys do that here. It's also important to remember, I run the ECMO program at Tufts for cardiogenic shock, and it's not a day job. So, as you know, VV, VA, VAV, VVA, BI-A, all of those configurations you have to be comfortable with. And especially in the cath lab, when you're doing this type of stuff, you've got to be very comfortable with managing these types of configurations. We do a lot of biatrial ECMO, where we put in a transeptal cannula as well as an RA cannula. And then we've done this through the internal jugular, where we put in the LA cannula from the neck for some of these patients. We splice both in, and now we're unloading both ventricles from the atria and then putting into the systemic circulation. So one of the major areas for this field of acute circulatory support is in the area of cardiogenic shock. And as you know very well, for the past 20, 30 years, there has been no movement on the dial in cardiogenic shock in terms of outcomes. Mortality for cardiogenic shock still ranges at about 50 to 60%, in the year 2016. And that's absolutely crazy if you think about the technology we have at our fingertips. And this is despite increasing use of primary PCI, increasing use of intra-aortic balloon pump, the mortality is still high. So the question is, what are we missing? And what I'll propose to you is that part of the issue is that we are missing the right ventricle when it comes to cardiogenic shock. So there are very few times in medicine where you can say always or never. And right heart failure always worsens mortality. It doesn't matter if you're in cardiogenic shock due to an RVMI, whether you're an advanced heart failure, left heart failure patient, or whether you're a pulmonary hypertension patient. Once the RV starts to go down, your short-term mortality starts to go up exponentially. And part of the reason for this is that RV function in shock remains poorly understood. We take a very univentricular thought process when it comes to shock. We're always focused on the LV and getting the LV stabilized. And we know from prior studies, this is Alice Jacobs, which is on all of your board exams, which is the take-home point that RV shock has the same mortality outcome as LV shock in the setting of AMI. So the RV is obviously just as bad as the LV when it comes to becoming dysfunctional. And so why is it that I think that univentricular shock is uncommon? So there are a couple of reasons. The ventricles are closely coupled together. And one of the ways they're coupled together is just by the coronary circulation. So when you have a Prox-LAD occlusion come into the cath lab, what you're seeing is that there's no longer a perfusion of the interventricular septum. And as a result, 40% of your RV contractile force is derived from that septum, so the RV is inherently involved even when it's a left coronary issue coming into the cath lab in cardiogenic shock. So one is they're coupled by coronary anatomy. The second is that they're coupled by coronary hemodynamics. So this is a classic study from 1997, basically showing that as your RA pressure starts to climb, your left coronary blood flow starts to decline. And the reason for that is you start to develop congestion within the coronary sinus, and that coronary venous congestion reduces that transmyocardial perfusion gradient, and all of a sudden global myocardial perfusion starts to come down with elevated right heart filling pressures. This also becomes a ventricular issue. So when the RV starts to dilate, starts to impinge on the left ventricle, you also see a significant reduction in LV perfusion just by virtue of the mechanical impingement of the interventricular septum on the left ventricle. And one of the most important determinants of RV function is afterload. And if you were to take aortic pressure or pulmonary artery pressure, increase it by 30 millimeters of mercury in each case, in the case of the left ventricle, you would see a minor decrement in stroke volume. But for the same magnitude of increase in pressure, you would see a precipitous drop in RV stroke volume. And so what that tells us is that the RV is highly sensitive to increases in afterload. And afterload is a very sticky business. People have a lot of trouble wrapping their head around afterload. And it's important to remember that when we're talking about the right ventricle, we're talking about pulsatile load on the right ventricle. So afterload is a composite of multiple different hemodynamic metrics. One is pulmonary vascular resistance, one is pulmonary vascular impedance, and the next is PA compliance. And so when the right ventricle ejects blood into the pulmonic circulation, this antegrade wave of blood flow hits multiple bifurcation points, millions of them in your lungs. And this backward reflected wave is that impedance wave. And when the green wave hits the blue wave, there's an increase in pressure and there's a decrease in flow. And so what this means is that when you have basically patients who have pulmonary arterial hypertension, this impedance wave is augmented. And you start to see that the PA pressure goes up and flow through that pulmonic circulation goes down. And this is that concept of pulsatile load. So when the RV is working against this, it's working not only against just the resistance of the vessels, the compliance of the vessels, but also this backward reflected wave coming back towards the pulmonic valve. And as we talked about earlier this morning, there are a number of hemodynamic formulas out there, and these are all based on a PA catheter, RA pressure, PA systolic diastolic, mean PA LA, and cardiac output. And each of these hemodynamic measures something very different. But the formulas to assess the coupling of the right ventricle, the pulmonary artery, and the left ventricle are actually somewhat confusing. And so there's RA wedge pressure ratios, pulmonary vascular resistance, pulmonary gradients, there's RV stroke work, compliance, elastance, and then the pulsatility index. So one of the papers that helped me understand this concept came from Ryan Tedford and Dave Cass. And in this patient population of patients with advanced left heart failure, they were looking at pulmonary venous congestion. And what they found was that the left atrium acts like an amplifier for right ventricular afterload. So if you have a wedge pressure of 40, you've got a significant drop in PA compliance and an increase in PA resistance. And now your RV has got a significant pulsatile load that's in part being magnified by the left atrium. and that's that concept of left heart failure as a primary determinant of right heart failure. So from our clinical practice, we started to look at this concept of pulsatile load just by taking care of patients. So this was one of our earliest tandem RVAD patients who came in with an RVMI, and when the patient had revascularization of the RCA, still remained hemodynamically unstable, we looked at the PA tracing and we could see that the PA pulse pressure was 5 millimeters of mercury. It's 35/30 with an RA pressure of 22. We put in the tandem continuous flow RVAD. We found that there was nice unloading. Here at this point it's non-pulsatile. And every day we're doing a turn down with the tandem RVAD, and we found this return of pulsatility at about day 5. And now the PA pulse pressure was 21 and the RA pressure was 7. So it didn't take too much of a rocket scientist to figure out that this PA pulse pressure divided by CVP actually could help us understand what is the functional capacity of the right ventricle. And that's where this concept of pulsatility started to become a clinical reality. And so we came up with this formula called the PAPI. And the PAPI is essentially your PA pulse pressure divided by your RA pressure. And in this simple formula where you don't have to calculate or quantify cardiac output, which can be very challenging in the setting of RV failure, TR, for example, what you have here is a measure of pulmonary of RV contraction with PA systolic pressure. You have a measure of left-sided filling pressures with PA diastolic pressure, and you have a measure of right atrial pressure, venous congestion on the right side. And so by looking at venous congestion, stroke volume, measures of arterial compliance, as well as precapillary pulmonary pressures and LA pressure, we now could basically use this PAPI index. And so when we came up with this formula, the idea was the Red Sox were doing very well at the time, so PAPI obviously stuck as a name. But this low PA pulse pressure and this high RA pressure intuitively makes sense. If you're a surgeon and you actually see this in the OR and you see minimal pulse amplitude on the PA, you know there's a problem with the RV. And you look at the central vein and it's congested, you don't need to have a Swan-Ganz to figure that out. In the cath lab, you do, but in the operating room, you don't. So our first paper back in 2010 was looking at patients coming in with bona fide RVMIs. And what we found was that if you're having an RVMI, your PAPI was 1 or less. And actually, the PAPI correlated directly with echo scores of RV failure. And then we found that if you had a low PAPI, you were more likely to die in the hospital or need a temporary RVAD. And this actually correlated well with our RA wedge pressure ratio, which is our other hemodynamic metric that we use for RVMI. So then we started looking at whether the PAPI correlates with established metrics of RV stroke work, echo scores, and there was a nice correlation. So we took this concept, and around the same time, Kormos had just published his paper looking at predicting RV failure in the setting of LVAD implant. And both papers were published in 2010. And of course, as you know, as soon as the RV goes down and you're going in for an LVAD, that becomes a significant predictor of mortality or survival after LVAD implant. So there have been a number of scoring systems trying to tackle this problem. You guys have a nice one here that Ash showed me nicely this morning. And what we did was we took our PAPI formula and ran it through INTERMACS in 2,900 patients in their data set and found that just short of INTERMACS Profile 1, the PAPI was a very highly significant predictor of the development of RV failure after LVAD implant. We then said that we needed to look at this in our own internal data set, so we looked at our 132 patients undergoing continuous flow LVAD, and we wanted to look at all those formulas that are out there. So the fellows basically looked at RA pressure, RA wedge ratios, stroke work, compliance, elastance, and the PAPI. And what they found was that the established metrics of congestion, those were markers of RV failure, but the PAPI, especially below 1.5, started to predict who's going to develop RV failure after an LVAD implant. And to our surgeons, that became a really important metric in terms of how we identify the need for concomitant RV support. And in our analysis, the AUC for PAPI was about 0.94 in this population of patients undergoing continuous low LVAD for predicting RV dysfunction and RV failure. Now, the same analysis was done by our colleagues at Stanford, and we were very happy to see that in our 132 patients, they corroborated the analysis with their 80 patients of continuous flow VAD, and they again found that the PAPI was a highly significant predictor of the need for early RVAD after LVAD implant. So the predictive power of the PAPI is something that we're still studying, we're still learning a lot more about. And I think as we talked about this morning, the PAPI probably falls apart when you start to get into the pulmonary hypertension patients and you've got an elevated PA systolic pressure. And so I agree with the way your CART analysis is looking at this idea of PA systolic pressure less than 75. That's where you're going to start to see the PAPI actually make a difference. But this becomes really important when we're making decisions in patients with cardiogenic shock. If you're going into battle and you've got a console in front of you and you do this, you're going to die. And basically, when you go into a cardiogenic shock scenario, the data that's on this console are your hemodynamic data. And if you do not look at hemodynamic data, your patient will die. So what we recommend to everybody with cardiogenic shock is that you put in a PA catheter and you look at the data. And this actually helped us understand this concept that univentricular shock is a myth. When we looked back at the analysis of the shock trial, this is the Finke paper from 2004, which defined the term cardiac power output. Scott basically put in his analysis a table which looked at all the coronary distributions for patients coming in with AMI shock in the shock trial. And when you look across the board, the RA pressures are all elevated, and the RA wedge pressure ratios are elevated, and the PAPI is all around 1.0 in these patients. So it told us, just from a quick look at a paper from 2004, that there's probably some subclinical RV dysfunction in almost all of these patients in the shock trial. So we approached Judy Hochman, who was very kind and was available to share her data with us. We then took the shock trial hemodynamic data set, and we created a simple scatter plot of RA pressure and wedge pressure. And when you look at all the patients coming in with cardiogenic shock, you start to see a very interesting split into 4 quadrants. And the majority of these patients fall into the LV dominant group, where the wedge is up but the CVP is down, or they fall into the BiV group, where the wedge is up and the CVP is up. And our CVP being up is greater than 15, so as a marker of biventricular involvement. And so this started to suggest that univentricular shock is actually more uncommon than we thought. And in fact, that biventricular involvement is probably more common than we think. And it turned out in the analysis, we defined RV dysfunction, RV failure. About half the patients in the trial and half the patients in the registry had some degree of RV dysfunction or RV failure. And if you met criteria, we used the Recover Right trial criteria. If you met criteria for an RP, based on the entry criteria for the trial for the IMPELLA RP, you actually were more likely to die in the shock trial than if you didn't meet those criteria. So what it suggests is that in the shock trial, where they tried to isolate out patients with isolated RV failure, they didn't include those patients. The patients who they thought were LV dominant shock actually had probably more biventricular failure than was being recognized. And I think this is part of the reason why the shock trial was a negative trial. There was no significant difference in early revascularization or balloon pump use in these patients because both ventricles were involved and were thinking in a univentricular way. So we started to look at our own data set at Tufts, and we started to look at the patients with cardiogenic shock who come in and get an IMPELLA device. And what we found was the exact same scatter plot as from the shock trial. Basically, a number of patients were falling into the biventricular group and the LV group, but not so much in the RV group. So again, suggesting to us that biventricular dysfunction is actually fairly common in patients coming with cardiogenic shock. And our outcomes with IMPELLA utilization for these patients in shock is about 36% died, but 28% recovered and 36% bridged to VAD. So when you look at this in terms of looking at shock outcomes, this is about as good as it gets for these patients coming in who are getting a mechanical support device. And when we looked at our ECMO data set for our shock patients, we found, again, a very similar distribution of the RA wedge pressure analysis, a lot of them in the biventricular group. And what we found was that in contrast to the IMPELLA group, our mortality was about 68% in patients getting VA-ECMO, even with best practices, antegrade perfusion, limb preservation, and LV venting. And a small number of patients were bridging to recovery and to LVAD in these ECMO patients. So it suggests that in the acute support arena, we've got to look at those hemodynamics and use that to help us guide our decision making. So our algorithm for cardiogenic shock is shown here, and what we recommend is early use of a PA catheter for acute MCS utilization in the setting of cardiogenic shock. And this can be AMI or otherwise. And LV dominant is defined here by CVP wedge and a PAPI. And if you've got LV dominant shock, we'll consider our first line device an IMPELLA CP or a 50cc balloon pump. And with the balloon pump, I put a red box around it because now we're beginning to question in these patients who are multiple pressors who we don't think are going to be stabilized in cardiogenic shock with a balloon pump, we'd go straight to a CP in those patients. If it's RV dominant, we go to an RP. If it's biventricular, it gets more tricky. We'd actually go to a BiPELLA with CP on the left or 5 on the left and an RP on the right. Or we'll go into VA-ECMO, especially if they're hypoxemic. So the take-home message here is let the hemodynamics guide your decision making. And our metrics, besides a cardiac index less than 2.2, are RA, wedge, and the PAPI. And so this evolution of percutaneous biventricular support is also spurring the field on, especially if we start to think that shock is not a univentricular problem. So we started off with IMPELLA 5.0s and tandem RVADs, then we did 5.0s and RPs, and now we do a majority of CP-RP when we're going on percutaneous BiV support in the cath lab. And I'll show you some hemodynamics just to hit the point home. This I won't run through the case too much, but this is a 58-year-old ischemic myopath who came in with decompensated heart failure, got developed VF, gets a single defibrillation. He's not intubated. I'm rounding on Monday morning, and he's hypotensive. His EF is now 5%. He's got severe RV systolic dysfunction. And the RA pressure is 26. His index is 1.4. The RA wedge pressure is 1.3, and the PAPI is far below 1.0. It's 0.6. So for this type of patient, we were discussing whether to do VA-ECMO or biventricular impellas. And the problem with VA-ECMO is I can't ambulate my guy. I can't take one ventricle out at a time. I can't support one ventricle and see how the RV is recovered and just leave the LV in. And with the 5.0 RP, we hadn't done this before, but the idea would be that if we can take the RP out, I can ambulate him with the 5.0 and we can find out who this guy is and if he's a candidate for advanced therapies. So there's a recent paper, which I won't go into, but this is a circulation paper looking at biventricular failure with VA-ECMO and showing that VA-ECMO, the outcomes are still pretty poor across the board with VA-ECMO for cardiogenic shock. And if you're getting past 3 days, the likelihood of surviving on VA-ECMO drops precipitously. So if you're going to do VA-ECMO, it's got to be a quick bridge. Otherwise, you're not going to get out of there. There's no exit strategy beyond that point. Shelley Hall down the street here basically has looked at Impella 5.0 for advanced heart failure patients. And her take-home message at ISHLT was that 67% of these patients are bridging to next therapy or recovering. So this idea of getting adequate unloading is critically important. The patients who did not survive, again, had moderate to severe RV dysfunction. So it suggests that that biventricular involvement is playing a major role for these patients. So for this patient, what we did was we put in a 5.0 device. And this is that Langston catheter, once again, indicating it's a guy who we think has biventricular failure. We're putting in a 5.0 device. Here's the LV-AO relationship, and here's the CVP of 24. We activate the 5.0 on the left side, and this is what the hemodynamics did within 100 heartbeats. The LV pressure went from about 60, it came in pretty hypotensive, came down to about 20. And the AO pressure came up with the 5.0 device, but the problem is the RA pressure also climbed from 24 to 28. So we're now beginning to overwhelm that right ventricle. If you're a surgeon and you see this, what you're seeing is suction event in the operating room, low flow on your VAD, and your RV starting to distend. If you're a hemodynamicist in the cath lab, you can't see that. You've got to look at your hemodynamic dashboard, and the Langston really helps you understand that coupling interface between the LV and the AO. So within a couple minutes, we start setting up the RP, and the LV pressure is now 5, and the AO pressure is hanging in there at about 68 before we can get the RP in. The CVP within a period of 15 minutes has climbed to 34, and the RV is getting more and more congested. So that leads to that hypoperfusion systemically. That's what's going to drive VF if you don't get this RV support device in. RV starts to come back up with the RP device. Now we're returning all that preload to the left ventricle, and the CVP comes from 34 to 22, and now we're on a bipella configuration. This is a pulsus paradoxus from overt RV failure, and that goes away once you're on the BiV support. So this idea of putting in biventricular support allowed us to stabilize this guy percutaneously, no sternotomy, no major incision. By day 5, he's now pink and peeing, which is what our surgeons are looking for VADs. And also now we see the cardiac index is up. The creatinine was 1.8, came down to 0.8. What we're doing now is we're putting in the RP and leaving it in through the surgery. So the HeartMate 2 gets put in, and the RV is still supported throughout the surgery. We leave it in for about 24 hours post-operatively, or 48 hours, and the RP is removed. Patient goes home with just a univentricular support system for a patient who otherwise we thought had overt biventricular failure. So the PAPI is what we use to identify these patients. We also use it as a weaning parameter. So once we start to see recovery, we know we can explant this RV device when we do those turndowns every day. And this concept of this Langston method, we're starting to use in the cath lab quite a bit. So here's a patient, when you go in the cath lab with these cases, ask your team to put in 4 transducers, RA, PA, LV, and AO. And when we activate a CP device, which I didn't think could do the same thing as a 5.0, we found that actually the same thing happened. Very narrow pulse pressure on the aortic tracing in white. LV starts to uncouple from the aortic tracing. And within a period of minutes, our LV pressure is 5 down here, and the AO pressure is hanging in there. We activate an RP device, and then the LV gets reloaded again. And interesting, you see a split between the PA and the RA because you've now uncoupled the right atrium from the pulmonary artery by putting in the RP device. So this idea of biventricular uncoupling using 2 rockets in your chest basically can be done to maintain these biventricular shock patients without the need for a major incision or a sternotomy for sure. And these types of patients, what we're doing is we're bridging them to recovery. This is a patient who came in myocarditis, complete heart block, biventricular failure, CP-RP. Within about 5 days, we've explanted stepwise. RP comes out first, CP stays in, and they go home with their own heart. And now this young kid's doing great and doesn't need to have more advanced heart failure therapy. Now, we've seen this as a reproducible event where we've had other patients come with BIV failure, and again, we can recover these patients. And this is on P3 BiPELLA, and we're getting recovery function. They can go home and be seen in the heart failure clinic. So this idea of doing BiPELLA, I think, is a new one, especially if we believe that univentricular shock is less common. We're now collecting a multi-center experience with BiPELLA around the United States, and what we're finding, very similar to the surgical literature, is that in all the patients who survived through BiPELLA, they had the devices implanted simultaneously in the same setting, CP and RP, or biventricular support. If you do a staged approach, you're more likely to be in the group that didn't survive. And so this is an important point that we'll be studying more over the next year, is how does the RV play a role in cardiogenic shock? Is it biventricular by nature? And if it is biventricular, how are we going to manage that type of patient? And should we be thinking about using more of these biventricular support strategies? And I think, again, coming back to it, it's the hemodynamics that will drive our decision-making in stabilizing these patients. So I'll end with just a few comments here on acute MI shock, which is a separate bucket. What we've been working on is this concept of primary unloading in patients who come in with AMI. So for patients who come in with AMI, primary STEMI, if they're not in shock, we'll do primary reperfusion therapy, and I think that's the gold standard. If they're in cardiogenic shock, more often our tendency is to go ahead and put in some sort of support device and then reperfuse the artery. We stabilize the hemodynamics, and then we focus on the coronary issue, which is reperfusion. If they have impending shock, it becomes more of a challenge, meaning that your blood pressure is still above 90, your patient looks like they're mottled, they're not doing well, and they're having a STEMI. The concern is that if you just open the artery, you're going to potentially drive forward that process of cardiogenic shock. So in these cases, we'll put in a PA catheter in the cath lab, get a quick measurement of an RA sat, sometimes it's sufficient. And if it's below 50, we'll go on support, and then we'll open the artery. And so this idea of going from primary reperfusion to primary unloading is now entering our algorithm for AMI shock. And the reason why we think this is that if you think about it, myocardial oxygen supply is what all interventionalists tackle in a STEMI. We open the artery, we restore supply. The problem is that we don't have anything that deals with myocardial oxygen demand. And as soon as you unload the ventricle, remember that triangular shape of the pressure volume loop, when your heart's not doing as much work, now you've immediately stopped that propensity for myocardial ischemia because you've taken away demand. And as a result, now you can stabilize your patient and you can open up the artery safely. So we agree that time is muscle, but if you put in an unloading device first, we believe this concept may actually stop that injury clock and allow you to bridge a lot of these patients more to recovery and let them go home with a smaller infarct size. The biology behind this actually gets fairly complex, but we've been working on this for some time. What we find is that in the primary reperfusion group, there's a significant shutdown of cardioprotective signaling in the heart, and this ratio of BCL2 to BAX is an apoptosis signal, and this seems to drive towards apoptosis or cell death. If you put in a pump and you wait 30 minutes before you open the artery, what we're finding is that actually all of these cardioprotective signalings are upregulated, and we shift this ratio towards an anti-apoptotic, anti-death mechanism, and you get myocardial protection. And this becomes critically important because in our lab, I don't trust actually even our own data, so I always try to send it out to another lab, get a blinded group to look at it. So what we did was we took a number of infarct samples from our preclinical models, sent it over to the Broad Institute at MIT. They're blinded, and we asked them to run a transcriptomics analysis. So they ran 19,000 genes in these infarct samples, and what they found was that the algorithm that they used computationally basically stratified and could identify the normal samples from the samples that were treated with primary reperfusion. All the gene sets that were here actually all went down. All the gene sets that were here all went up. And compared to the primary unloading group, where this starts to look a lot more like a normal ventricle. And so just by using this, we can see that there's a global shift in gene expression by first unloading, then reperfusing, as opposed to reperfusion alone. And now what we're seeing is that in this survival model, this is the infarct area here by MRI in our pig models. We're seeing that there's a significant infarct injury 28 days later, but this is now cut down substantially if you do a primary unloading mechanism. So what we're saying is that instead of just being an interventionalist, we're asking our interventionalists to start to become heart failure preventionalists, if you will. And the idea is that they would first unload, then reperfuse, and reduce that burden of injury. And whether or not this pans out, the idea is that down the line in these cath labs across the United States, these will not just become primary reperfusion labs, but they become primary unloading labs. They put in a PA catheter like we used to do to get the data in those patients who are borderline impending shock, and they unload, and then they go ahead and reperfuse when it's safe to do so. So with that, I'll introduce this concept of the Acute Cardiac Unloading and Recovery Symposium, which will be at ESC. The deadline for abstracts is July 11th. So anybody who has an interest in acute unloading and myocardial recovery, if your abstract gets accepted, you'll be funded to go to the meeting. So we'll see you in Rome. For the fellows who are interested, we have a dual training pathway for interventional and heart failure. As Jerry indicated, we have a number of fellows who've now basically completed that pathway, and we have a one-year fellowship in preclinical and clinical research in acute MCS for fellows who are interested in this type of work. So with that, thanks very much for your attention.